Thank you very much, Mr. Chairman. Many thanks for the invitation. Good afternoon, ladies and gentlemen. We are going to discuss in the next minutes about how we are going to stimulate patients with PCOS for in vitro fertilization. So what is the most efficient way to do that, and what is the most safe way to do that? Of course, before ovarian stimulation for IVF in these patients, other options are considered as a first-line treatment, such as lifestyle changes, ovulation-inducing agents, clonfensitrate, insulin-sensitizing medications. If no conception occurs, gonadotrophin treatment or LOD. And if all these fail, not necessarily in this order, if all these fail, then in vitro fertilization is the next step. So ovarian stimulation for IVF in PCOS patients presents several problems. We may encounter understimulation in these patients with production of less follicles than what we hoped for, or overstimulation and very frequently occurrence of ovarian hyperstimulation syndrome. And this is not a complication and a side effect, it's a life-threatening situation. Deaths from OHSS are estimated to be 100,000, although most of us would agree that this is probably an underestimation due to under-reporting. So this is really a serious complication that we create to our patients. So a lot of options have been put forward to solve this problem in these patients, such as no ovarian stimulation, IVM, or sometimes modified IVM, metformin pretreatment. Some of us have put forward this issue of which gonadotrophin should be the best in PCOS patients, which analog should we choose to suppress premature late surge, what should be the triggering signal for final oocyte maturation, and perhaps segmentation of ovarian stimulation. In vitro maturation, what we mean by that is oocyte collection from the ovaries of women with PCOS in an unstimulated cycle. And then maturation occurs in vitro prior to insemination. This is the most pure form of IVM, although some colleagues have proposed priming with gonadotrophins in minimal doses. In IVM, there are a lot of studies which are non-randomized comparisons of IVM versus conventional ART. Non-comparative case series, RCTs comparing IVM protocols. All these show that IVM is a feasible option in women with PCOS, as favorable maturation, fertilization, pregnancy, and live birth rates have been reported, while pregnancy complications and congenital anomalies appear to be similar to those occurring in conventional IVF. However, there is absolutely no comparison, randomized comparison of IVM to conventional ART. So at the moment, until more evidence or until evidence is available, IVM may not be the preferred first-line treatment for subfertile women with PCOS. It's an exciting field, but we need data. Some of you voted for metformin. Should we pretreat our patients with metformin prior to IVF? The rationale is, of course, to improve IVF outcome through a reduction in intra-ovarian androgens, which lead to an improvement in oocyte quality and fertilization. This is the assumption, and also a reduction in OHSS rate. Metformin, we know it enhances insulin sensitivity in the liver, in the peripheral tissues, reducing insulin resistance, insulin secretion, and hyperinsulinemia. So that's theory. The data regarding its use in PCOS patients for IVF, we're talking about 5 IVF trials, about 400 patients with PCOS who have been treated either with metformin and IVF or just IVF. Meta-analysis is by Costello a few years ago, and shows that less FSH is required when we use metformin in these patients, about 300 units less. However, estradiol on the day of ECG is not different, Number of cumulus oocyte complexes is the same. OHSS rate, the authors claim that we have a significant reduction in the OHSS rate in PCOS patients pretreated with metformin, showing this impressive odds ratio. However, if you calculate the rate reduction, you see that it's 12%, but it just touches zero. So yes, it is an effect there, but it's probably marginal when you treat patients with metformin. At the same time, neither the pregnancy rate or the live birth rate are different between the two treatments, simply IVF plus metformin. Which gonadotrophin should we choose for these patients? Should it contain LH? Should it be recombinant, urinary? Unfortunately, to be honest, there are no comparative data regarding this issue, regarding the outcome of IVF in PCOS patients stimulated with different gonadotrophin preparations. What we only have in our disposal is data from ovulation induction cycles in which no outcome difference are to be seen between gonadotrophin preparations. This is in IVF. It's a big comparison adjusted for baseline conditions between HMG and recombinant FSH. This is general population, of course. We know that in the general population there is not much difference to be seen, so one has no real reason to suggest that it should be different in PCOS patients. But no data are actually available. Which analog? Currently the use of analogs in worldwide is about 60 to 40, agonists versus antagonists. Should it be different in PCOS patients? We tried to approach this issue a few years ago. This is a meta-analysis by George Grissinger in 2006. Very few studies at that point, showing that duration of stimulation when you use antagonist in PCOS patients is shorter. No difference in gonadotrophic consumption, no difference in the number of oocytes. Clinical pregnancy rate was similar. An OHSS rate, but we are talking about only two studies at that point, could not show a difference between agonists and antagonists in PCOS patients. But we now are in 2013, and this is the 2011 meta-analysis by the Cochrane, the last published updated meta-analysis between agonists and antagonists, and this is a subgroup in PCOS patients, agonists versus antagonists, rate difference minus 10%, which means that if you treat your patient with antagonist instead of an agonist, the chance that the patient will show OHSS is 10% lower, and this is statistically significant. And it might be even higher, the difference, considering that in that meta-analysis, a lot of patients in the agonist group, significantly more, were in fact coasted, which means that the actual difference in OHSS rate, if coasting did not occur, could be even higher. So I think there is not much to discuss here. Clearly, the use of antagonists in PCOS patients will reduce but not eliminate occurrence of OHSS. Which triggering signal? The use of antagonists allows us to use agonists for triggering final oocyte maturation due to this competitive blockage of antagonists to the GnRH receptor in the hypophysis. And this was done a few years ago. A lot of years ago, in fact, started in the 90s when there were no analogs at all, and it continued in the antagonist era. This is a collection of data from George in 2006, about 500 patients, high-risk patients, triggered with GnRH agonist, zero OHSS, severe OHSS in these patients. And there are more studies, another 1,500 patients, again, high risk, treated with agonists, no severe OHSS. So one could very easily ask the question, after more than 2,000 patients, high risk for OHSS, triggered with agonist, and no severe OHSS, why do we still use ACG for final oocyte maturation in these patients? Why do we still use agonists, which do not allow agonists for triggering oocyte maturation in these patients? When we do that, when we replace ACG with GnRH agonist, we proceed to oocyte retrieval. Collection of oocytes is no problem at all. The same with fertilization. But when we do a fresh transfer, and this is the meta-analysis by 2005, so fresh transfer after agonist triggering and normal luteal support, then the chance of pregnancy is significantly lower. So you are not allowed to transfer in the fresh cycle after agonist triggering, because your chance of pregnancy will be significantly lower. You shouldn't in any case, because if you do that and you achieve a pregnancy, you will probably induce late HSS. In any case, some of our colleagues thought that we must solve this problem. We should combine the best of two worlds, both achieve no HSS and sustain the chance of pregnancy. And how can we do that? Simply by adding back ECG in the luteal phase. And this is a meta-analysis they published in 2010 in Human Reproduction Update. These are the initial studies, agonist triggering, fresh transfer, usual luteal phase support, decreased chance of pregnancy. And these are the new studies with the addition of ECG or intensified luteal phase support, which shows that the chance of pregnancy is not different, and HSS was 0. This morning, and I think in the rest of the Congress, we will see a lot of data. We live in the era of data, and we should know this data. But most important is that we understand this data. So if you just change the order of the studies and classify patients according to their high risk or low risk for HSS, these are the same studies in the previous slide. And also take into account if there was an intensified luteal phase support or a corporal luteal stimulation, then the picture changes and there is no difference in HSS to be seen. So in that study, this is a letter we published in Update after this study was published, it's clear that until now there is no reduction in HSS rate when you add ECG in the luteal phase. And to take it from the beginning, we have to understand what we are doing. We don't want ECG in the system because ECG is the main problem for inducing HSS. And then we introduce ECG again. Inevitably, one could assume that this would lead to some HSS. And if we are successful in our transfer, we may achieve a pregnancy and induce a late HSS. That's in theory. But now we have also a few studies since that publication, and this is a study by Radesic and Tremelin. They used agonist triggering plus one bolus of ECG, 1,500 units. They had one case of severe late onset HSS. Humaidan 2009, 12 patients, one bolus of 1,500 units of ECG, and one severe case of HSS. Castillo in 2010 repeated luteal boluses of 250 to 1,000 units of ECG in 192 patients, 8% moderate or severe HSS. Shapiro, this is the dual trigger, agonist plus ECG at the same time to induce final oocyte maturation, one late onset HSS. This is not surprising. This is not surprising. If you introduce in the luteal phase what you try to avoid initially, inevitably you will have some HSS. You may have a reduced rate of HSS compared to the classical conventional ECG, but you are not eliminating HSS. In order to do that, you have to do something else, which has been described as IVF segmentation. Publication by George in 2007, George Grisinger, 20 patients at high risk for developing HSS, Stradiol more than 4,000, more than 20 follicles. They freeze all 2PN oocytes, transfer them in the subsequent cycles, and zero HSS, and of course they sustain the chance of pregnancy. Finishing this presentation, I will show you how we stimulate patients with PCO, polycystic ovaries, or PCOS, at the Unit for Human Reproduction at the Medical School, Aristotle University of Thessaloniki. So, our inclusion criteria: indication for IVF, presence of PCO ovaries, more than 14 follicles greater than 11 millimeter on the day of triggering, Stimulation 150, this 300 is for some obese patients that were resistant in previous cycles. GnRH antagonist daily from fixed day 5 or flexible after day 5. Criteria for triggering 3 follicles of 17 millimeter and triggering with triptorelin 0.2 milligram. ESHRE IVF, we freeze all oocytes at 2 p.m. stage, and patients were instructed to report any symptoms associated with OHSS, in which case they were examined at the clinic. Admission in the hospital was performed only if we had severe OHSS. The thawing cycles were performed with hormonal substitution, and transfer was according to the Greek law up to 3 embryos. We're talking about 111 patients prospectively studied, PCO ovaries in all patients, PCOS in about 50% of them. Male factor was also present in some patients. Age 32, BMI 24. Mean FSH starting dose 170 units. Mean antagonist starting day 5.7. Mean duration of stimulation 10 days. Mean total dose about 1,900 units. These are the values on the day of triggering. As you can see, estradiol is 4,100, so really intense stimulation. And patients had a mean of 26 follicles, more than 11 millimeter. We got about 19.5 COCs. Fertilization rate was about 55%, and a mean of 10 2PN oocytes were frozen. Severe HSS was in 0 patients, and also none of the patients reported nausea, abdominal pain or distension, oliguria or feeling unwell. Duration of the luteal phase, 5 to 10 days. We got 2PN oocytes 847, who have thawed so far 506 embryos, and still frozen are 341. 60 cycles have been performed with a mean of 1.4 per patient. The biochemical pregnancy is 49%, the ongoing is 38%, and the cumulative after these cycles that I show you is about 68%, which is not a very surprising outcome because these are very good prognosis patients in any case. But it shows that you can achieve a very nice cumulative pregnancy rate in these patients with 0 OHSS. So let me come to the conclusions for this presentation. I think we can suggest that no association between the type of gonadotrophin used for ovarian stimulation and outcome difference can currently be supported in PCOS patients undergoing IVF. The use of antagonists as compared to agonists in PCOS patients undergoing IVF is associated with a decreased duration of stimulation, decreased gonadotrophic consumption, and a similar probability of pregnancy. Pretreatment of PCOS patients with metformin does not improve the probability of pregnancy, although it may marginally reduce the chance of HSS. In PCOS patients, segmentation of ovarian stimulation by replacement of ECG with agonists for triggering final oocyte maturation appears to be an attractive option since it maintains the probability of pregnancy and eliminates the occurrence of OHSS. Thank you very much for your attention.
Yes, thank you very much. The presentation is now open for discussion, please. Anybody in the audience having any comments or questions? Yes, please, if you come forward, state your name, where you're from, and your question, please.
Adam Balin from Leeds, UK. Stratis, thank you very much. An excellent overview. And can I ask you, with your current protocol, do you ever abandon cycles, or will you always trigger and freeze?
No, we have not abandoned cycles, although the maximum number of oocytes was in 1 to patients above 40, 45, 46. In these cases, you may consider abandoning the cycle not because you're afraid of HSS, but because you may have other complications such as torsion, perhaps. But so far we haven't done it, and we didn't have any such incidences. But the number is small, so I understand your concern.
And do you use dopamine agonists in that scenario ever?
Use, sorry?
Dopamine agonists to prevent the consequences of hyperstimulation.
You use agonists for triggering?
Dopamine.
Dopamine, like cabergoline.
I'm sorry, I cannot hear you.
Dopamine?
Dopamine, no.
Yeah.
No, we do not use dopamine. If there is concern for OHSS in patients that have not been triggered with agonists after antagonist stimulation, and we run in such a difficult scenario, what we do is we give antagonists in the luteal phase. This has been shown in case series, and the maximum number of patients we included was 40 patients, that in established severe OHSS, antagonist in the luteal phase for 4 or 5 days very quickly demolished the OHSS. So that's what we do, although it's not evidence-based.
Thank you for your presentation. I'm Dr. Smita from Oman. 2 questions. One is, in the morning we heard how androgen helps the follicles to grow. How do you explain that in PCO the excessive androgen doesn't help the eggs to grow so well?
Doesn't help, sorry?
Doesn't help the eggs to grow so well. We have found a detrimental effect. We've always been taught that there's a detrimental effect of the high androgen in PCO for ovulation. So do we forget about this now?
No, we don't forget about it, but what we do is segmentation. So we transfer the embryos in a completely different cycle. So whatever environment was there during ovarian stimulation, whatever discussions, published literature regarding the effect of estradiol, progesterone, whatever environment, it's simply not applicable. Now, the quality of the embryos that you get, it still needs to be explored, but it seems that with the embryos we get, the pregnancy rates is probably very high to worry about.
Okay. And we used to give dexamethasone in PCO women.
Could you please speak up a little bit so it's easier?
We used to give dexamethasone in PCO women. Do we still do it or we don't?
You can. You can also use metformin. You can use unproven interventions such as coasting. But all these interventions, if you believe that they are worth doing it, they will just decrease the incidence of OHSS. What I would like for my patients, and I think that most of us would share that, is to look the patients in the eye and know that it's impossible for her to get OHSS because of your wonderful interventions to produce follicles and oocytes. And this can only be achieved with agonist triggering and no games in the luteal phase.
Thank you. We have a question over there.
Hani Mustafa from Hartlepool, UK. I'm asking you.